Welcome back to Falcon Physician Reviews for a discussion of thyroid pathology for the USMLE Step 1. Starting with the basics, an overview of thyroid gland. It produces thyroid hormones. The precursor dietary iodine is required. It's regulated from anterior pituitary secretion of TSH. And serum T3 and T4 are bound to thyroid binding globulin, in addition to albumin as well. Moving to some pathology, in terms of congenital abnormalities, the thyroglossal duct cyst can occasionally be seen. This does not alter normal thyroid function. The thyroglossal duct cyst is a remnant of the thyroglossal duct. It's ectopic thyroid tissue which can be found anywhere along the path of the thyroglossal duct. It's really an anatomical abnormality which has minimal clinical significance. Goiter. Goiter is simply a large thyroid. It has no implications in terms of thyroid function. There can be multiple etiologies for goiter. It may be physiologic. It can be in response to production of TSH in response to hypoactivity of the thyroid gland. So, for example, in certain areas endemic that have a deficiency of iodine, iodine lack can cause goiter. So in that situation, the thyroid gland is not getting enough of its substrate iodine, and so the pituitary is stimulating enlargement of the thyroid with TSH. Certain foods are goitrogens. For example, broccoli and cabbage are goitrogens, and these foods suppress synthesis of thyroid hormones. Again, you would get a compensatory increase in thyroid size by TSH stimulation. And then you can have enzymatic deficiencies of thyroid hormone synthesis, which can cause goiter. Again, goiter, however, is simply a large thyroid. It does not describe the functional state of the thyroid. The terms euthyroid or hyperthyroid or hypothyroid are more appropriate. So non-toxic implies a euthyroid, and that a euthyroid implies a normal amount of thyroid hormone production. Toxic implies hyperthyroid, implies a thyrotoxic state. There's an excess amount of thyroid hormones. And then hypoactive implies a deficiency of thyroid hormones. The term nodular goiter implies a large thyroid goiter that has multiple nodules. Now, these nodules may either be hot or cold. And hot is almost always a benign. When you have a hot nodule, that implies that it's taking up a lot of radio-labeled iodine, and that implies that it's a functional nodule. And functional nodules are rarely cancerous. They're almost always benign. However, cold nodules can be cancerous. They're oftentimes benign, but they can be malignant as well. So a cold nodule is one that does not take up significant amounts of radio-labeled iodine. The clinical features of hyperthyroidism, I think most medical students are familiar with these. Weight loss with preserved appetite, heat intolerance, tremor, which is usually a fine tremor, inability to concentrate. You can have some proximal muscle weakness. You can have cardiac effects, tachycardia, palpitations. You can have atrial fibrillation as a result of hyperthyroidism or from hypothyroidism. And you can get bone wasting, osteoporosis, if this goes on chronically. You can also get diarrhea. Laboratory workup of hyperthyroidism includes an evaluation of the TSH and potentially T4 and T3. So you may see an increased free T4 and a low TSH, and you may see an increased T4 and T3 resin uptake. So in the T4, of course, thyroxine is the prohormone, which is converted to the metabolically active T3. You'll have an increased T4. You will, if you measure T3, you'll have an increased T3, but that's a difficult bioassay. The T3 resin uptake implies that there's decreased binding sites on thyroid binding globulin, and the relationship of T3 resin uptake is it's inversely proportional to binding site availability on thyroid binding globulin. So if you have decreased binding sites for T3 because someone is hyperthyroidism, you'll then therefore have increased T3 resin uptake. That's a bit confusing, but hopefully that makes sense. Causes of hyperthyroidism include diffuse hyperplasia, for example, Graves' disease, ingestion of exogenous thyroid hormone, a hyperfunctional pituitary that's hypersecreting TSH. That's going to be very rare, but you have to keep that in mind for boards. And a hyperfunctional adenoma of the thyroid, and then thyroiditis. Classically, we think of thyroiditis causing hypothyroidism, but in the initial stages, the initial weeks, it's typically characterized by hyperthyroidism. And that's not hyperthyroidism in the sense that the thyroid is producing too much thyroid hormone. That's caused by a leaching out or a leaking out of thyroid hormone from the follicular lumen. The other thing to point out about thyroiditis and other causes of hyperthyroidism is that if you do a radio-labeled iodine uptake, most causes of hyperthyroidism will have diffuse or localized nodular uptake, increased uptake, whereas thyroiditis will be diffusely decreased. In terms of Graves' disease, this is one of the most common causes of hyperthyroidism. It's termed diffuse toxic goiter. It's due to autoimmune production of IgG, thyroid-stimulating immunoglobulins. These bind to the TSH receptor, and rather than destroying the thyroid gland, actually mistakenly overactivate the thyroid gland. So this is an autoimmune etiology. There are some stigmata that are specific for Graves' disease. For example, the ocular exophthalmos. You may also see pretibial myxedema, which is a localized infiltrative dermopathy. Graves' disease is much more common in women, and there's an association, an increased incidence with HLA-DR3 and HLA-B8. Laboratory workup of hypothyroidism, you'll see a decreased total and a decreased free T4. You'll have a decreased T3 resin uptake, so let's go through this again, make sure it makes sense. With hypothyroidism, you're going to have increased available binding sites for T3 on thyroid binding globulin. Therefore, the inverse relationship with resin uptake, you'll have decreased T3 resin uptake. Okay? You'll have an increased TSH from lack of feedback inhibition, and you may have dyslipidemia. Hypothyroidism can cause cretinism in infants and children, and this can be caused by iodine lack. It can be caused by enzymatic deficiency. It can be caused by failure of organ descent, and it can be caused by anti-thyroid antibodies from the mother that can cross the placenta. Clinical features, unfortunately, these patients have severe mental retardation. They typically have short stature. They can have coarse facial features. They have macroglossia or a large tongue, and they can sometimes have a protuberant abdomen with an umbilical hernia. Severe hypothyroidism that is chronic in nature and not treated can result in myxedema, sometimes referred to as myxedema coma, although these patients typically don't have coma. They may have some mental status changes, but not classically coma. Now, myxedema is caused by an accumulation of glycosaminoglycans and hyaluronic acid. So these are matrix substances which accumulate in the skin, subcutaneous tissues, and the viscera, and they're responsible for the myxedema. Hypothyroidism in adults can occur from any number of a variety of etiologies. Surgery, thyroid resection, for example, for hyperthyroidism, radioactive iodine ablation for Graves' disease, or irradiation to the neck. Multiple drugs can cause hypothyroidism. Hashimoto thyroiditis is the most common cause of hypothyroidism in adults. There's primary or idiopathic, or a lack of iodine. In the United States, this is extremely rare, but there are countries where this occurs. Clinical features of hypothyroidism, there's slowing of physical and mental activity, occasionally with weight gain, cold intolerance. There's broadening and coarsening of facial features, constipation, and there may be a low-pitched voice. Moving now to thyroiditis. Thyroiditis is defined as inflammation of the thyroid gland. They have multiple causes, include infection with pathogens such as mycobacteria, fungal, pathogens or pneumocystis carinii. There is Hashimoto's thyroiditis, subacute granulomatous thyroiditis, and subacute lymphocytic thyroiditis. Hashimoto's thyroiditis is the most common cause of hypothyroidism in areas of the world where iodine levels are sufficient, for example, Europe and the United States. It's characterized by gradual thyroid failure because of autoimmune destruction of the thyroid gland. It's prevalent in adults aged 45 to 60, and it's much, much more common in women than men. The ratio of females to male is typically 10 to 20 to 1. It's associated with HLA-DR5 and HLA-B5. The pathogenesis, as mentioned, it's associated with autoantibodies to thyroglobulin, thyroid peroxidase, to the TSH receptor, but in contrast to Graves' disease, these are not stimulatory antibodies, they're destructive antibodies, and to the iodine receptor. The pathology, on biopsy, you'll see a lymphocytic infiltrate with germinal centers. You may see Hurth cells that are prominent. You'll see diffuse enlargement of the thyroid gland. And hypothyroidism may be preceded by transient thyroid toxicosis due to disruption of thyroid follicles and release of thyroid hormones. And this was previously mentioned. With any thyroiditis, you may get transient hyperthyroidism. This may go on for several weeks. Eventually, however, the gland becomes shrunken. So here's a pathology slide showing a thyroid parenchyma, and showing the parenchyma contains a dense lymphocytic infiltrate with germinal centers present. You see residual thyroid follicles lined by deeply eosinophilic Hurth cells. Moving now to subacute de Quervain's thyroiditis. This is a focal destruction of thyroid tissue by granulomatous inflammation. It can be caused by mumps or Coxsackie virus. It's a limited course with flu-like symptoms with a painful tender thyroid, and this is much more common in women. So if you see most causes of thyroiditis are not painful. In fact, subacute de Quervain thyroiditis is classically the only cause of painful thyroiditis. So if you see a thyroid exam that is enlarged and tender, you really have to think about de Quervain's thyroiditis. Moving now to thyroid cancer, we'll start with thyroid adenomas. These are discrete solitary masses. There's a variety of histologic patterns, but the key is well-circumscribed capsule without invasion. The clinical features, these can present as a painless mass. They're usually non-functional, so cold nodules on a scan. And larger masses can produce local symptoms such as dysphagia. There's a representation, a schematic here, showing a discrete solitary mass which is well encapsulated. Risk factors for thyroid cancer, things that should be concerning, include solitary nodules, nodules in young patients, nodules in males, a history of ionizing radiation exposure, and nodules that are cold, that do not take up iodine on uptake scan. Moving to thyroid carcinoma, most cases occur in adults. There is still a female predominance. The subtypes include papillary, follicular, medullary, and anaplastic, the most common being papillary, the second most common being follicular carcinoma. Medullary carcinoma and anaplastic carcinoma, fortunately, are rarer, and I say fortunately because these have a worse prognosis. Risk factors for thyroid carcinoma include ionizing radiation. The pathogenesis often involves the RET proto-oncogene. It plays a primary role in papillary and medullary thyroid carcinomas, and the RET proto-oncogene encodes a tyrosine kinase receptor. We'll start with papillary carcinoma. Overview, this is the most common form of thyroid cancer. It can occur at any age, but most often in young adults between 20 and 40 years of age. It has a high incidence in patients with Gardner syndrome, which is familial adenomatous polyposis coli. Clinical features, patients may present with an asymptomatic thyroid nodule. They may present with hoarseness, dysphagia, cough, or dyspnea. And most papillary lesions are cold masses on skinty scans. So if you see a cold mass, that's concerning. It may be benign, but it is concerning for malignancy and requires further workup. Fortunately, the prognosis is excellent. Even if lymph nodes are involved, papillary carcinoma is a slow-growing tumor, and it responds well to radioactive iodine treatment as well as surgical intervention. Here we see a pathology slide of papillary carcinoma. And what you see is well-formed papillae lined by cells with characteristic empty-appearing nuclei. These are sometimes referred to orphan Annie-eye nuclei. And you can see these in the right-hand corner demonstrated by the arrows. Moving now to follicular carcinoma, this is the second most common form of thyroid cancer. Fortunately, this also has a reasonably good prognosis. Clinical features: it's a slowly enlarging, painless nodules. Again, like papillary carcinoma, it can have cold nodules on a thyroid scan. It invades hematogenously rather than through the lymphatic system, so it invades the vascular system, and this is treated with lobectomy or subtotal thyroidectomy. A pathology slide here exemplifies follicular carcinoma. You can see that a few of the glandular lumens contain recognizable colloid. Moving now to medullary carcinoma, this is a neuroendocrine thyroid tumor which is derived from the parafollicular C cells. And this pathologically or histologically is a sheet of tumor cells in an amyloid stroma. Clinical features: paraneoplastic syndromes are common with medullary carcinoma. You may have diarrhea due to secretion of VIP. These tumors may secrete calcitonin, causing hypocalcemia. And you have to think about the multiple endocrine neoplasias 2A or 2B with medullary carcinoma. So it's important to ask about a family history or a prior history of pheochromocytoma or a pancreatic islet cell tumor, or prolactinoma or pituitary adenoma, I should say. RET proto-oncogene is important in the pathogenesis, and the peak incidence varies between age 40 and 50 years. Finally, anaplastic carcinoma. This is an undifferentiated tumor of follicular epithelium cells. It's a very aggressive tumor and has a very poor prognosis, unfortunately. Mortality, in fact, approaches 100%. The mean age at diagnosis is roughly 65 years of age. Clinical features: pathogenesis, it may be related to loss of the p53 tumor suppressor gene. It's a rapidly enlarging, bulky neck mass, and there may be neighborhood compressive symptoms such as dyspnea, dysphagia, hoarseness, and cough is common.